Welcome to the lecture for eating disorders. What we have here are celebrities whom we believe have gone through the experience. The group on the left had a history of bulimia nervosa, while the group on the right had a history of anorexia nervosa. Most eating disorders begin in the early teens to mid-20s. Although they commonly occur following puberty, there have been recorded cases of anorexia nervosa starting as early as 7 years old. Now, a good number of your patients may experience a disturbance in their perception of body shape and weight. They see themselves as fat despite being very skinny, or that they equate their self-worth with how much they weigh. Also, a good number of your patients may experience depression and anxiety, and it is because of these mood changes the eating disorder is triggered. Electrolyte changes commonly occur in eating disorders, which may lead to medical complications. But major cause of death in your patients is suicide. The mood changes in your patients may lead to low self-esteem, and they may fear losing control of their lives. It is because of this fear of losing control that your patients makes attempt to regain this control through their diet and their weight. I'd like you guys to read and understand the basic concepts of comorbidities and etiologies from your book. However, there's one etiology that I would like to get across, and that is neurobiological factors. Changes in serotonin levels may lead to changes in your patient's mood, leading to depression, which may trigger the eating disorder. Serotonin levels and the formation of serotonin is dependent upon the presence of an amino acid, which is tryptophan. Tryptophan is a form of protein which can be found only in food sources. Therefore, changes in protein levels is necessary in order to create changes in your patient's mood. Another is antidepressants that promote serotonin, such as SSRIs. They will only work once your patient's body weight has reached at least 90% as to the weight for height ratio. One of the clinical differences between anorexia nervosa and bulimia nervosa is the perception and behavior each one exhibit. In anorexia nervosa, the patient may refuse to maintain a minimally normal weight for height and express intense fear of gaining weight. While in bulimia nervosa, the patient may engage in repeated episodes of binge eating, followed by inappropriate behaviors such as self-induced vomiting, misuse of laxatives, diuretics, or even Ipecac, and may engage in fasting or excessive exercise. However, always remember, both disorders may exhibit binge eating and purging, as well as restricting, but differ as to its frequency, which helps define the disorder. When assessing patients with anorexia nervosa, consider a patient who is severely starved with dehydration issues, as well as changes in electrolytes and hormone levels. Remember, hormones need proteins in order for it to be synthesized. So typical assessments would reveal a body weight below 85% based on height and weight ratio, the absence of menstrual cycle, the formation of lanugo due to the lack of subcutaneous tissue, and your patient's thyroid hormones and RBC count will fall below normal due to nutritional deficiencies. Now, the risk of developing fractures increases due to electrolyte changes, specifically calcium. Now, when you compare it to a patient with bulimia nervosa, relying on weight alone is not a good indicator because your patient's body weight can be normal or slightly below normal but never close to 85%. So what you need to consider would be the consequence of the binge purge episodes. So typical assessments would reveal tooth erosion because of hydrochloric acid reflux, Russell's sign, which are scars on the hand or fingers used to purge, and your parotid gland will swell up. Remember, your parotid gland secretes enzymes that helps break down food products. The more your gland works, the greater the possibility that it will enlarge. Now, with the amounts of food your patient ingests, the stomach will try and accommodate the huge volume, leading to dilatation and increasing the risk of rupture. Now, here's a list of possible nursing diagnoses on patients with eating disorders. Always remember, the priority of care should focus on meeting your physiologic needs first and stabilizing the patient medically. The only exception to that is if your patient is suicidal, that you need to establish safety and seek out involuntary admission for the patient prior to meeting your patient's physiologic needs. One of the risks during rehabilitation of patients with anorexia nervosa is the development of refeeding syndrome. It is a rare but potentially life-threatening condition that can occur during refeeding of severely malnourished individuals. In starvation, the secretion of insulin is decreased in response to a reduced intake of carbohydrates. Instead, fat and protein stores are broken down to produce energy. This results in intracellular loss of electrolytes, in particular phosphate. Malnourished patients' intracellular phosphate stores can be depleted despite normal serum phosphate concentrations. So when they start to feed, a sudden shift from fat metabolism to carbohydrate metabolism occurs and secretion of insulin increases. This stimulates cellular uptake of phosphate, which can lead to further hypophosphatemia, eventually leading to symptoms such as respiratory failure, cardiac failure, hypotension, arrhythmias, seizures, and even death. Nursing interventions for patients who restrict food includes negotiating a reasonable contract for meals and starting your patient with a minimal amount of calories in a given day, which is spread across 6 meals. The reason being is you're trying to avoid a sudden influx of electrolytes and fluids, which may increase the risk of refeeding syndrome. You also include your patients during meal planning, and this is directed by your dietitian. Your patients are given food choices which are appropriate during rehabilitation. You also encourage your patients to keep a food diary to record all food ingested as well as thoughts and feelings associated with eating or not eating. The basic idea here is food and emotion has to be tied together. Otherwise, if your patient's diary reflects only the food ingested and how much calories has been consumed, it gives them the idea of how much calories they need to restrict during the next mealtime. You may also anticipate liquid supplements to be added by the dietitian, especially on patients who do not consume their meals during mealtimes. You also begin your patient's diet low in fat and milk products because fat and milk products are difficult to digest, and your patient may complain of abdominal discomfort. Nasogastric feeding is also an option, especially on patients who are very emaciated and electrolyte changes have already occurred. You also weigh your patient on a routine basis, early morning, after voiding, at the same time and same type of clothing. You also try and check for attempts to put weights on your patient's body because patients would want you to assume that they have gained some weight. Nursing interventions for patients who engage in binge episodes revolves around the basic concept of helping your patient understand their thoughts and emotions regarding their behavior. So I want you guys to be familiar with the interventions listed herein. Nursing interventions for patients who engage in purging behaviors include discussing with your patient how purging is used to cope with their negative feelings, as well as point out in a matter of fact that purging began as a method of control and that now the purging is out of control. Now, these are done during counseling sessions and not during informal visits. Another is during and after mealtimes, bathroom breaks are restricted not unless accompanied by staff. The reason being is you would want your patient to keep their meals down rather than engage in purging behaviors. However, if they feel the urge, encourage your patient to talk to staff and vent out their emotions. During counseling sessions as well, your patients are able to list the pros and cons of their eating disorder, which may help them gain insight into their behaviors. And the last one is help your patient identify secondary gains that are ultimate and unconscious purpose that disorder serves. This helps them gain insight as to why they continue to engage in purging behaviors. Nursing interventions for patients with a disturbed body image includes discussing with your patients how they perceive their own bodies, but never argue with your patient's perceptions. However, point out in a matter of fact what your perceptions are and be objective about your patient's bodies. Next is to discuss with your patients perceptions of other people's bodies, because this is where you can gain insight as to how your patient equates beauty and self-worth. The last one is to assist your patient to develop a self-esteem that is compatible with a healthy body weight. Milieu management in eating disorders is huge because it is mainly the therapeutic environment your patients are engaged during rehabilitation. So nursing interventions include having precise meal times, meaning your patient shows up during meals and consumes their food in a given specific amount of time. Usually your patients are given around 30 minutes to consume their meal tray. Another is adherence to a selected menu. It is true that we encourage patients to participate during meal planning, but it is your dietitian that calculates the calories per day and the amount of food that needs to be consumed for each meal. Your patients are also observed during and after meals for behaviors such as pocketing of food, spitting of food in a cup or container, or engaging in purging behaviors. Bathroom trips are also monitored after eating, after seeing visitors in hospital pass, trying to prevent purging behaviors, or your patients taking medications such as laxatives, diuretics, or Ipecac. Your patients' weight are also monitored regularly, and it is our responsibility to check for patients' attempt to put weights around their body. And the last one is maintenance of appropriate exercise after reaching acceptable weight at least 90% of their ideal body weight. So if you see your patient engaging in excessive exercise prior to reaching 90% of their IBW, you have to redirect their behavior and have them perform activities such as walking with somebody or trying to help out with any form of setup or any form of activity that does not encourage your patient to lose weight. As your patient approaches discharge, your patient is encouraged to expand the behavior to include eating out, preparing a meal for themselves, and eating foods that they have been restricting from before. If you're able to observe your patient being able to do any of these, it means that your patient has gained insight into their behavior and can continue recovery at home without the presence of a structured environment. The last but not the least among nursing interventions, any psychiatric symptoms such as suicide needs to be addressed immediately, and you may seek out involuntary admission for your patient. And after discharge, patients should submit for routine lab testing to monitor their electrolytes, glucose levels, thyroid levels, blood count, and ECG. Remember, an eating disorder can be a lifelong struggle for your patient, and what we're trying to avoid are medical complications that can be life-threatening. Now here's a list of community resources who help patients with eating disorders.